Good morning, everyone. Thanks for coming out early, as always. This is the last seminar of our Center for Clinical Trials seminar series this year, and we start up again in September. So we're finishing off with a bang with Taha, who's going to be speaking this morning about some of his experiences in Malawi and Sub-Saharan Africa and on HIV-1. Let me tell you a little bit about him. For those of you who don't know Taha, he's professor of epidemiology and population, family, and reproductive health here at the School of Public Health. He's co-director of the infectious disease area of concentration in the Department of Epidemiology. He's the principal investigator of the Malawi Clinical Trials Unit. This is a consortium of 3 institutions at Johns Hopkins, University of North Carolina, Chapel Hill, and the University of Malawi College of Medicine. And this consortium is affiliated with 4 HIV research global networks: the HIV Prevention Trials Network, the International Maternal Pediatric Adolescent AIDS Clinical Trials, that's called IMPACT Network, the Microbicide Trials Network, and the Adult Clinical Trials Group Network, that's ACTG Network, some of you may have heard of. His areas of research interest are HIV, heterosexual and mother-to-child transmission of HIV, prevention of HIV, genital tract infections, and microbicide research. So let's see, he's extensively involved in training here in the department and development of infrastructure and capacity building in Africa to support clinical service and the conduct of research. So I'll let him tell you more about what he's doing, and thank you very much, Taha, for speaking this morning.
Thank you very much, Dr. Dickinson. So what I will do is we'll share with you our experience. The process itself, or where we are right now, and how we got there. In between, you will see some results of the studies we have done. So it is not specifically about one study, but a series of studies. At the time when we started, we never thought we will be there for so long, and we never thought it will be presented after some time in an orderly way, as I will tell you. Hopefully you will think that it is in order. But it is an experience of 20 years. So let me start by just giving you my own biases and the way I organize the talk along 3 areas here. So the first is observational studies. And I hope many of you will believe me, that is a wonderful state. I mean, doing observational studies is very productive. I mean, there are no, the boundaries or the regulations that exist within clinical trials are different. So the experience doing observational studies, at least I can say in front of you that for my own professional experience or development, it was very useful. However, for how long can you do observational studies? And what I will present this morning is certainly in reference to the international experience. So you will see from what I will present that after doing observational studies for some time, then you will be in trouble. I mean, the policymakers, and especially if you are dealing with HIV/AIDS, they will tell you, for how long are you going to say that the prevalence or the incidence or the risk factors, and this is the impact? At one point, they will tell you, you can't do this. You have to find a way of stopping this epidemic. Then we move to clinical trials. Under not pressure, but we're recognizing that the impact of HIV is quite substantial, we thought we should do interventions. But doing interventions, not really knowing what you are intervening with or what you can apply, although it is the ethics of this state of equipoise under which we do clinical trials, you we soon realized in our own situation that the biological evidence and we obtain from observational studies and doing clinical trials is not always you get the results or the outcomes you want. So sometimes they do not agree. And this raises more debate and more discussion. The third part is probably the easiest one, but still it has got its own challenges, is when your science or the biological evidence and the results of you obtain from observational studies and the clinical trials, they agree and you get good results. Is that, does that mean, for example, all is well? There are certain challenges. The moment you get results of clinical trials, then you are under tremendous pressure to implement. And in the international setting, taking that one step further and implement results is certainly a challenge. So I will go through these experiences and share with you some of what we have learned over this period. And everything I say probably relates to Malawi. Malawi is in southern Africa. It borders Tanzania, Zambia, and sits inside Mozambique. It's about 2 hours from South Africa. There are very beautiful resorts there. Lake Malawi actually takes 1/3 of the country. So if you are thinking of a good summer, you can go to Lake Malawi. Let me give you an idea about HIV and why are we worrying about prevention of mother-child transmission. This is a story from the US. So in the US, we have done very well. And actually, you can see over time what has happened with transmission of HIV. I hate standing here, but it seems like I have to. So what has happened in the US, you can see the successes that had been made. Everyone started from around 25%. The rate of mother-child transmission, if no one is applying any intervention, no antiretrovirals, nothing else, comparably, be that in the developing world or in the developed world, the transmission around 6 to 8 weeks will be 25%. So that is from where everyone started. And then over the years, you can see where we are now. And this data is only up to 2002. Actually, today, it is very low to the extent that I'm not quite sure if CDC is still continuing to monitor this. But you can see that there has been substantial declines, and the rates that are reported today is less than 2%. Transmission is occurring. Of course, women do not breastfeed here in the US, so that is an important fact. So, what happened? Enhanced prenatal HIV testing, antiretrovirals, women are using HAART, and also use of selective delivery methods, be that cesarean section or otherwise. So this is what is happening in the US. So we know one thing we know is that it can be done. So we have the technology, we have the evidence that we can certainly reduce, and now we have become bold enough to say we can eliminate transmission of HIV from the mother to the infant. Okay. This is what is happening in Sub-Saharan Africa. In Southern Africa in particular, you can see some countries like Lesotho, Swaziland, Botswana, South Africa. The HIV prevalence among women attending antenatal care is more than 20% or probably more than 30% in some countries. It is declining, but you can still see that the HIV prevalence is very high. This is up to 2007, and I will show you the data from 2009. So this is the magnitude of HIV infection. According to UNAIDS report in 2009, 1.8 million adults and children newly infected with HIV, about 370,000 children infected were new infections, 1.3 million adults AIDS-related deaths among children and adults, and in some countries, as in South Africa and also in Malawi, the incidence, that is the rate of HIV acquisition among women of reproductive age in South Africa is 9%. So you can just see the magnitude of rate of transmission that is happening among women of reproductive age. These results are from microbicide studies. In Malawi, it is from the recent microbicide study we had in 2007. The incidence among women of reproductive age is 4%. So the rate of acquisition continues to be high, and the prevalence is high. So what happens to children who get infected? Just to give you an idea of why we worry about prevention of mother-child transmission. These are survival curves. So you can see this part. This is, so if we follow children up to 3 years, about 87% of them would have died. And by 3 years, only about 1 or 2% will be severely symptomatic. And then about 3 or 4% will be moderately symptomatic. And only less than 1% or so, or 1%, will be normal. So the fate of these children is that they will die. The vast majority of these children will die. This is if there is no infection. This is from our own studies in Malawi. That is the outcome if there is no treatment. How about survival of children? This is also from our studies in Malawi. This is some of the observational studies we did earlier to determine the magnitude of HIV transmission and the impact. So there are 3 lines here. The first one is children who are not exposed, meaning that they are born to HIV negative mothers. The second line here, these are children who are exposed, but they are not infected. They are born to HIV positive mothers, but they are not infected. This group is HIV infected infants. So you can see the survival of these children is very low, but one thing we know now is what to do, is just close this gap, bring this line in parallel or bring it close to these ones, okay? How can we do that? Probably by prevention and also by treatment. So, as you can see, the survival is quite inadequate for those who are infected. One slide about the risk factors. What determines transmission of HIV from the mother to the infant? First of all, transmission can occur during pregnancy, that is in utero, or at the time of birth, intrapartum, or postpartum after delivery through breastfeeding. So these are the 3 time points roughly where transmission occurs. So what are the major risk factors? Certainly maternal viral load is the most important determinant. Advanced HIV disease, women who are in stage 3 or stage 4 based on the WHO recommendations will be most likely to transmit. Immunological status, women with low CD4 will transmit more than those with high CD4. Duration of pregnancy, preterm and low birth weight, they are more likely to transmit. Prolonged rupture of membranes, usually we use 4 hours. If the membranes are ruptured for more than 4 hours, the likelihood of the infant being infected is high. Mode of delivery, vaginal compared to cesarean, is high. Genital tract infections, sexually transmitted diseases, and other genital tract infections. Lots of work has been done in this regard. Vitamin A deficiency, this was from our earlier studies, and I will show you one of the clinical trials. Women with low serum vitamin A were more likely to transmit. And the most important factor is breastfeeding. In Africa, women breastfeed at least up to 2 years. And it is very important that they continue breastfeeding. But how to prevent transmission and how to make breastfeeding safe, that is the major challenge. Mastitis is inflammation of the breast tissue, and also if there are any lesions in the nipples, so that goes with the mastitis. Okay, so these are the major risk factors. We got many of these actually confirmed in our own site in Malawi. Talking about breastfeeding, how much breastfeeding transmission occurs? This is from our site in Malawi. You can see here, so this is the rate of transmission. So these infants were started as uninfected at 6 weeks, and then we followed them up to 24 or slightly longer than that. So you can see the rate of transmission. So the cumulative HIV transmission at around 24 months is 10%. So that is infants who acquired infection due to breastfeeding. And actually, a major clinical trial was done in Nairobi, where they randomized women to formula feed or breastfeed, and they have shown that 44% of the transmission is due to breastfeeding. A clinical trial that will never be done again, I believe. So it was just challenging to do it that way. And today, I don't think it will be possible to do. But you can see from observational data we have that the rate of transmission is quite substantial, 10% due to breastfeeding. And in our own study, that we have shown that most of the transmission actually occurs early. So you can see during the first 1 to 5 months, the rate of transmission was about 0.7% every month, and then it declined over time. Okay. How much breastfeeding is going on? This is data 2007 from our last or our most recent clinical trial. Forget about the bars and what they each one of these, but you can see it is not different at each time point or infant age. So you can see about 90 or more than 90% of the women continue breastfeeding. Okay, so this is 6 months, still about 90%. After 6%, it declined because we told them to stop. We counseled them to stop breastfeeding, okay? But you can see that women do breastfeed, and they continue breastfeeding. If they are not counseled to do so, then they will continue breastfeeding up to 24 months or even longer. Okay, so to share our own experience, I started with saying observational studies. So during the period 1989-94, these are the early days of the HIV epidemic in Malawi. We did observational studies, conventional cohort studies. You just screen women. If she is positive, she is HIV infected, then you follow her over time. And most of the recruitment we did was in the antenatal clinic and the postnatal clinic. So if she is HIV infected, we follow her to see the rate of transmission if she is pregnant. And we also studied the impact. We also determined the risk factors. Very neat design. If you get money, you can do the study. So this was a straightforward cohort study. And then HIV negative women, you determine the rate of transmission. So that is from where we got the rate of infection. So those observational studies, cohort studies, were very useful. We were able to determine several risk factors associated with HIV acquisition and also transmission of HIV from the mother to the infant. However, in the mid-90s, it became very clear that the impact of HIV is quite substantial. And in the area of infant HIV, in the area of survival of the infants, that was very clear, that some of the gains obtained or achieved in the early 80s, safe water supply, nutrition, immunization, ORT, those achievements are now becoming reversed. So governments and also IRBs, whenever we submitted another study, they started to wonder, for how long are you going to do observational studies? So we started to think seriously about clinical trials. But as I said, we didn't know what works. All what we had was what we obtained from observational studies. We knew some risk factors are associated with transmission. So that is from where we got started. We wanted to apply some interventions, but the evidence we had was basically what we obtained from observational studies. What was happening in the US then? This is in 1994. If you remember the PACTG, the pediatric clinical trial of zidovudine became available in the US. And it showed that actually if you intervene with giving zidovudine or AZT to the mother during pregnancy, and also to the mother during the process of labor, intrapartum, and also to the infant, then you can decrease transmission of HIV by about 2/3, 67% reduction. That was a big achievement. So it became clear for the first time that actually you can give prophylaxis to the mother and the infant, and you can decrease transmission. As I said, in the US, there is no breastfeeding. So what happens after the postnatal or period, the first 6 weeks, was not a major concern. So in the US, at least, we had an intervention that works, and that is giving the mother and the infant zidovudine prophylaxis. That regimen in the US, in the African countries, was, at that time, it was very clear. It was very expensive, very complicated. You have to give zidovudine intravenously during the process of labor. So that regimen was thought to be expensive and not practical, and therefore not appropriate for resource-constrained settings. And we had a real debate about use of whether you should give zidovudine to women in Africa. What is the standard of care? Why should it be different here and there? So that was a big debate. But anyway, we in Malawi, we thought of 3 interventions. All of these were non-antiretroviral. So we thought of the first one. I will remark on it quickly, is the WASH study, cleaning the birth canal with an antiseptic solution, and that is the WASH study. And then the second one was supplementation with vitamin A antenatally, giving women vitamin A, and antibiotic treatment of chorioamnionitis, basically the association of genital tract infections with transmission. So for the 3, these were kind of sequentially, or they were not at the same time. So we had data from our own site and also from other sites that showed evidence that biologically these trials can be justified. So let me give you an idea about these trials. So the first thing I mentioned, this is rates of mother-child transmission in Malawi as of today, or as of now. So the early part I already covered. This was the 1989 to 94. These were observational studies, and we determined that the rate of mother-child transmission was 35%. However, the technology of determining if an infant is infected or not at that time was solely dependent on serology. You have to wait at least 12 months before you do testing of the infant. We didn't have PCR, and actually it wasn't available globally. It wasn't available to that extent in the African setting. So we have to use serology, and that is basically testing antibodies, okay? But if you do if you do the testing early, you will be measuring maternal antibodies, so you will get a false result. So we have to wait until maternal antibodies is not a factor, and then to see if if the infection is really infant infection based on serology. So we have to wait at least 12 months. So this estimate is based on 12 to 18 months, and there is a big problem here. If you wait until 12 months in Africa, these children will never come back to you. It is not only lost to follow-up, but also the rate of death is high. So by testing after 12 months, there are some real challenges. But that is the rate of transmission we obtained from our own site. In fact, later on, we discovered that we were within the limit of transmission. Studies by Kevin DeCock and others, they did review of several studies, and they reported up to 45% using serology as well. So this is the rate of transmission at the time, the early period when we were doing observational studies. The other studies actually used PCR. And all these studies up to here is based on 6 to 8 weeks. This is at 9 months. So for these are comparable at least the time of testing. Okay? So this is a WASH study. We did the WASH study, and you can see the rate of transmission was 28%. It is obvious that it didn't work. So this is, we reported this in more than one place. the effect of birth canal cleansing with, we use chlorhexidine. Chlorhexidine is a broad spectrum antiseptic. We use 0.25%. The procedure is very simple. Every time the midwife will examine the progress of labor, will take a cotton soaked in chlorhexidine and just wipe the birth canal to remove the secretions, and also the infant is cleansed immediately after birth. So the process is very simple. Chlorhexidine costs, actually, this intervention costs 5 cents per woman. So it is very practical. It can be done, and we did it. We were thinking that it will. Have you heard of Ignaz Semmelweis? He is known as the father of hospital epidemiology. He's the first to have recommended washing and cross-contamination in the hospital. However, he was not received very well by his peers. So if you read about him, it's a very interesting story. He's a Hungarian obstetrician who trained in Austria. But his ideas then were quite novel, and it was not received well. So the WASH study, this is the biological evidence we had then. In the early 90s, several reports confirmed that most of the transmission occurs in the birth canal. And this is why we thought just cleaning the birth canal, removing the infectious material in the birth canal, will reduce transmission. And using chlorhexidine, we thought we will leave some residual antiseptic as the process of labor continues. So we knew that about actually 50 or more than 50% of the transmission occurs in the birth canal, intrapartum. Studies also suggested that transmission of HIV, and these are very interesting studies. If you don't have anything to read, you can read the studies about twins. The first twin actually gets infected more than the second. As you would imagine, the first will do all the hard work, and then the second will come very quickly. So studies amongst twins showed that the first twin it gets infected in the birth canal, or it gets infected more than the second. Other studies targeting perinatal infections, that is group B, streptococcus, in the Scandinavian studies, they showed that actually cleaning with chlorhexidine is very effective, and also it is safe. So we had some safety data. So all in all, we have the biology, and we have some safety data, and we have a very effective or very simple intervention. We also had some secondary objectives. Will this simple intervention decrease perinatal transmissions, things like sepsis, neonatal death, and maternal sepsis? So we had those secondary outcomes, but our primary outcome was infant HIV infection. So it wasn't possible to do an individual randomization. We did the study at the Queen Elizabeth Central Hospital. It is a very large tertiary teaching hospital. 50 to 60 women deliver every day in this hospital. And to make things difficult, and there was a report actually last week or a week ago that the mortality is higher in the U.S. hospitals, or at least in the U.S., among those who deliver, or not deliver, among those who attend the hospital over the weekend. So it is not only in Malawi, but everywhere it seems that when there is transition from one shift to the other, some adverse outcomes could occur. So we were not certain, or we were not able actually, in having 50 to 60 deliveries every day, to do individual randomization. So it was just impossible to do that. Although we had 80 nurses in the labor room. I mean, 80 nurses working for us, nothing but to deliver and also apply the intervention. Despite all that, it was not possible to do individual randomization. So what we did is a relatively innovative design, is to do the intervention during the months of June, July, and November. That is no intervention. And then the intervention in between, August, September, and October. So we did the study in blocks of time. So this is the results of the clinical trial itself. And as I said, there were no differences in transmission. You can see during the no intervention, the transmission was 28%, and during the intervention, it was 27%. So cleaning the birth canal using an antiseptic, although very simple, it didn't reduce transmission. Only when you do subgroup analysis, you stratify this by rupture of membranes, duration of rupture of membranes, do you see a significant effect. So for women who were in labor for a long period, that is more than 4 hours, and the membranes were ruptured, you can see some effect due to the intervention. Our fellow obstetricians, they felt that these results are very important, and they wanted us to endorse it in a more stronger tone, but I think we prevailed. We thought that just doing subgroup analysis, we can just report it as what we see. But the disappointing fact is that this simple intervention did not reduce transmission of HIV. Okay. However, there were some very good results, and these are the outcomes related to sepsis, perinatal outcomes. This is the rate of admissions. You can see this is when there was no intervention. So, and then this is during the intervention, huge decline. And then when the intervention was stopped, you can see the rebound here. We have also data about neonatal sepsis, huge reductions, 50% reduction in neonatal sepsis and early neonatal death, and also maternal sepsis. So there were reductions in all the secondary outcomes, but not in the primary outcome. Okay, you will see this slide again. So this is the time where this is the WASH study, and then we moved to the vitamin A, supplementation with vitamin A. We had strong data from our site and also from other sites. But as you can see, vitamin A supplementation didn't work either. The rate of transmission is about 27%. So let me show you a few things about vitamin A. So part of the observational studies we did earlier was to identify risk factors. And we measured vitamin A in HIV-infected women. And we had very convincing results. So 21.9 among mothers whose infants survived 12 months, the mean vitamin A concentration was lower among the women, among mothers of infants who were infected compared to the mothers of infants who were not infected. And also there was a very nice gradient. The lower the serum vitamin A level, the higher the rate of transmission. So we had evidence, or we had data to suggest that actually that transmission is associated with transmission. These data were published in the Lancet, and it received good reviews. And so it's 3 clinical trials at our own site, and then one in Tanzania and one in South Africa. All these trials, by the way, none of these trials were successful or show efficacy in reducing transmission. So we are not alone in this regard. But we had the data, and we had to intervene. So we provided supplementation with vitamin A. So all women received vitamin A in the treatment arm, received vitamin A in addition to iron and folate. And the other group, they received iron and folate. So it didn't work. There were huge reductions, actually, huge improvements in birth weight, but it didn't decrease the rate of transmission. So vitamin A didn't work either. Then we were preparing for a third trial, and that is treating genital tract infections. Chorioamnionitis, that is inflammation of the fetal membranes. So we thought we had data to suggest that genital tract infections are actually associated with transmission of HIV from the mother to the infant. So we thought, why don't we treat chorioamnionitis then? And that is what we were working on when a landmark study became available. The results of the HivNet 012 study from Uganda, our colleagues here from the School of Medicine, Brooks Jackson, Laura Gay, and our colleagues in Uganda, they did this study. And they showed that, and this was the first antiretroviral trial to be done in Africa to show effect on transmission of mother-to-child transmission. They showed that if you give the mother single dose of the drug nevirapine at the time when uterine contractions start, at the time of birth, and also give it to the infant within 72 hours of birth, single dose, one drug or one tablet to the mother, and to the infant, just one oral dose to the infant within 72 hours. This simple regimen decreases transmission by about 50%, 40%. So that breakthrough became available while we were preparing for another clinical trial, which was not based on antiretrovirals. So in Africa, this single dose nevirapine, it became known as the HIPNET 012 regimen, became the standard of care. So, as I said, we were about to start this clinical trial. So what we did, this is a biological justification. The hypothesis was that the inflammatory processes could be associated with transmission of HIV during pregnancy and intrapartum. So what we have done is to add the standard of care to the clinical trial which we were starting. And if you are doing clinical trials, it is really, you have to be patient. So it was not an easy process. When you recalculate all your sample size, the effect size, you can just see if nevirapine is going to take do a reduction of 50%, then our job became harder to see with a very smaller effect size if the antibiotics will work from that smaller effect size. And certainly this intervention didn't work. Also, it had very good effects as far as reproductive outcomes are concerned. So the design itself, HIV women were randomized at 20 to 24 weeks of gestation, and then they either received the antibiotics or the placebo, and the antibiotics were metronidazole and erythromycin, substituting with ampicillin for erythromycin intrapartum. All women received, and children received the nevirapine regimen as a standard of care. There were no differences in the proportion of infants with HIV infection at time of birth, which is indicative of intrauterine transmission, or postnatally at 4 to 6 weeks. So there were no differences in rates of transmission. So we are now here. You can see this is the antibiotic treatment intervention. The rate of transmission of about 16%. The difference here most likely due to the nevirapine intervention. So it didn't work. Then after that, these are the good days actually, when you find that the interventions do work. So antiretrovirals do reduce transmission from mother to the infant. So starting from 2000 up to 2009, actually, we conducted 3 clinical trials. 2000 to 2003, we conducted 2 simultaneous clinical trials. These are known as the NAVAS or MVAS trials. The design was very simple. If the woman is HIV, so there were 2 groups of women here. There is a group of women in Africa, we know them very well, we call them late presenters, meaning that they come to the labor room, but they come very late, about to deliver, meaning they will deliver most likely within 4 hours. The problem is that you don't know their HIV status. So if you wanted to do the counseling, the testing, it will not be possible, neither logistically, and also earlier on, we were using serology. So you have to send the blood to the lab, and if it's during the day, then you will not know until the morning. Right now, we have rapid testing, so that is helping very much. But in the early days, it was not possible to get counseling done. And as you know, these women will also be worrying about something else than HIV at that point. So it was not logistically possible. So these are known as late presenters. What is the proportion of late presenters in Africa? It has come down significantly. Right now, it is probably, in Malawi, it is probably 20 to 30%. But when we did these trials, it was 70%. 70% of the women whom we saw in the labor room were actually late presenters. We didn't know their HIV status when they came for delivery. And in Malawi and in several other African countries, there is a term called BBA. Do you want to guess what BBA is? BBA is born before arrival, meaning that the woman actually, her intention was to deliver in the hospital, but she will bring the baby with her. So every morning you go to the labor room, you will find 11, 12, you read the count there, 11, 13 BBAs, meaning that the woman brought the baby with her. So it wasn't, it was quite a challenge, but this right now, I think the rates of late presenters are declining. So we conducted 2 clinical trials. If she comes late, we enroll her in the late presenters study. And if she comes early, meaning that we can do the testing and establish her HIV status before she delivers, then she will be in the early presenters. So this is the design. It is very simple. This is for the late presenters. So the women who come late, there is no way you can test them here. So they don't have, they cannot receive the single dose nevirapine, the standard of care, because we don't know their HIV status. Okay? But you have the baby. So the baby was randomized to either receive nevirapine plus zidovudine or receives nevirapine only. So the idea of adding zidovudine here was twofold. One is that the woman didn't receive nevirapine. Therefore, what is available to the infant through the placenta is nil. Therefore, we have to compensate for that by another drug. Zidovudine is the only drug we knew about. Its safety, so we added zidovudine. So it is a very simple randomized trial. And this was actually a very important study because this was the first study to show post-exposure prophylaxis. If we give the infant alone prophylaxis using nevirapine and zidovudine, will this work? And this study actually showed very well that yes, the rate of the efficacy is much higher if you gave the infant post-exposure prophylaxis. Of course, there is another twist whenever you use antiretrovirals, and that is the issue of resistance. So here, not giving the mother nevirapine and development of resistance to nevirapine is very quick, and it's almost universal. I mean, the infants or the mothers will develop resistance. So if you don't give nevirapine to the mother, then probably you have saved the mother or at least the mother will not develop resistance, and you need to worry only about the infant. So the Navazo studies, the late presenters and the early presenters, the results from the early presenters were very similar to what they have seen in Uganda. So that was just a confirmatory, and it showed that actually it is the same like in Uganda. The late presenters was also very effective in reducing transmission. So these studies provided the evidence that post-exposure prophylaxis does work. But the problem with these prophylactic regimens is that it protects up to 6 to 8 weeks. And there is, if the women are going to breastfeed, then you can save the infant up to this point, and then they continue breastfeeding, and then they will become infected. So the infant is at risk as long as they are breastfed. So just giving a short course prophylactic regimen was not enough. And we started thinking about how to extend this. The problem is we didn't know for how long. The safety of these drugs, we didn't know. So we took the challenge that we will do the prophylaxis up to 14 weeks. And the 14 weeks was purely logistical, because that is the time when infant immunizations are complete in Malawi. So we said we will do the prophylaxis up to the time when the prophylaxis would have been completed. And therefore, we started another clinical trial. It is called the post-exposure prophylaxis to the infant, PEPI Malawi, and it has been published about 2 years ago, a very large clinical trial that enrolled about 3,500 at a single site. It was a phase 3 clinical trial in a single site, and the prophylaxis was up to 14 weeks. And the outcome was infant HIV infection at 9 months, not 6 to 8 months, like we have done in earlier studies. Breastfeeding HIV-infected women were enrolled and then randomized. This is the randomization. So the control arm is the standard of care that became in Malawi following the Navraza studies. That is, give the mother nevirapine at the time of birth, and then give the infant single-dose nevirapine, and also give the infant, in addition to single-dose nevirapine, zidovudine for 1 week. So this was the control arm. And this was actually based on our earlier clinical trial of the Navraza study. And then the extended nevirapine arm, it is just like in the control, and then give the infant nevirapine alone daily for 14 weeks, up to age 14 weeks. The second arm, we added zidovudine here to see if it will make the reduction higher, and also it will reduce resistance. So the second arm, the same, the control regimen, and then the infant received nevirapine and zidovudine daily up to age 14 weeks. The women were counseled to stop breastfeeding by 6 months. So this was the design of the PEPI study. And these are the rates of transmission. A wonderful study. I mean, compared to the disappointments we had, this study and the Navraza study as well was quite informative. So you can see here, this is the control arm. This is the rate of transmission. These are Kaplan-Meier curves. And then you can see the red here is the nevirapine plus zidovudine, and the green one here is the nevirapine alone. So there are no differences between the nevirapine alone or nevirapine plus zidovudine. And you can see substantial differences between the control and the treatment arms. So at 9 months, our endpoint here, in the control arm, the rate of transmission was 10.6. You can see in the extended nevirapine, it was 5.2 and 6.4. And these are statistically significant. And this is the protective efficacy of these regimens compared to the control. You can see during the period of administration of the antiretrovirals, the prophylaxis was given during the first 14 weeks. You can see the rate of reduction is quite substantial. Just like in the ACTG study in the US, it is about 67%, or at 9 months, it's actually still 50%. So we have taken this regimen all the way to 14 weeks, and we have shown 50% reduction. And so this was published earlier. So what about women who were eligible for treatment? Meaning they are eligible, meaning that they have low CD4, and they should have been treated with antiretrovirals, just like in any healthcare. While we were doing this PEPI clinical trial, antiretrovirals were introduced in Malawi through the Global Fund and PEPFAR. So we had the opportunity actually to refer the women who were eligible. If their CD4 were low, less than 250, then we referred them for treatment. And some of these women did receive treatment. So among the women who received treatment, the rate of transmission in their infants was reduced to 1.8 per 100 person years. So you can see, if you give the infant prophylaxis and the woman is given heart, you can actually reduce the transmission down to the levels of what we see here in the US, 1.8%. So you can see from what we have shown here up to 24 months, and then here the rate of decrease or protective efficacy during the 14 weeks when transmission, when the prophylaxis was provided. And then if you can add also maternal heart. The problem is these infants continue to be breastfed. After 14 weeks, they are still at risk. The prophylaxis will work very well up to 14 weeks. After 14 weeks, then these infants will again be at risk if the woman is continuing breastfeeding. And this is the rate of transmission actually after 14 weeks and up to 24 months. So the cumulative rate of acquisition of HIV in these infants, be that in the control or the extended nevirapine or extended nevirapine plus zidovudine, is very comparable here. It is about 7%. And you can see that every 3 months, the rate of transmission increases by about 2%. So we have a problem that you save the children up to 6 to 8 weeks. Well, up to 14 weeks, then still there is a problem or a residual amount of transmission that is going on as long as the women are breastfeeding. If you are thinking that why are they breastfeeding, actually that is the best thing that they can do. The infant will die due to diarrheal diseases. The amount of morbidity that occurs if they stop breastfeeding outweighs the amount of benefit that they will accrue due to not transmitting HIV. So we actually advise these women to continue breastfeeding. This is based on what the WHO has revised, but at the same time we tell them the risk that is involved. So there is some transmission that is going on, and as you can see, it is substantial. So the PEPI Malawi and other studies provided consistent evidence that extended prophylaxis with antiretrovirals to infants and HIV-infected mothers can substantially reduce reduce mother-child transmission of HIV. And based on this data, the WHO recommended, actually, this is the recent or the current recommendations from WHO, that if a woman received AZT during pregnancy, daily nevirapine is recommended for her child from birth until the end of breastfeeding period. So the WHO has extended this, and they said throughout the breastfeeding period, our own clinical trial and also 2 clinical trials that came after that, they confirmed our results. So, but none of these clinical trials were throughout the duration of breastfeeding. If a woman received 3 drugs, that is heart, during pregnancy, then the woman should continue the regimen of 3 drugs prophylaxis throughout the period of breastfeeding. So, as I said, none of these options have been evaluated in a randomized clinical trial. But the WHO made the recommendation that prophylaxis should continue throughout the period of breastfeeding. A large clinical trial, it is known as PROMISE, have just started, and we are one of the sites actually, to do this clinical trial, and that is giving the prophylaxis throughout the duration of breastfeeding. So this clinical trial has just started. And these are the rates of transmission. I think last time we stopped here. So this is the PEPI study, showed 5.2% at 9 months. And then if you add actually maternal heart, it becomes 1.8%. So that is where we are right now. I actually wanted to share with you, how we moved through this process, determining from observational studies to clinical trials, and in between, I hope you saw also some of the data we have at this point. Thank you.
Time for questions.
So talk to me about how you guys were feeling from 94 to 2003 with a series of 3 trials, none of which worked. but you had fantastic ancillary outcomes for all three of those things. And those of us who were in the child health community and not in the HIV world were kept counting on seeing the paper that would kind of roll out after the New England Journal paper that would say, well, sorry, didn't find anything, where you found some really great stuff. But you had an almost 10-year period there where kind of nothing you seemed to do worked for HIV.
It is, certainly true. I think, I will tell you my own personal experience is to counsel people to be patient, and of course it is, but it is not easy. So that being said, I think what we saw, for example, in the WASH study, and what we saw in the vitamin A supplementation study, and also in the chorioamnionitis trial, all the secondary outcomes that relate to the health of the infant and the child were very good. So I think that interest was important to see those results. The disappointing part is that, yes, it didn't decrease HIV transmission. So at that point, it was very, very difficult. Neither do other people knew what to do. I mean, so there was only zidovudine, the regimen as it is here in the US up to this point. So either you do the zidovudine, which at that time will cost $800 per year per woman, or you do nothing. So we thought what we were doing actually was very good. So.
Great advertisements for secondary outcomes.
Excellent presentation. I'm glad to see that better than 90% of mothers are not transmitting after 2004. I was wondering if those who are transmitting is because of the resistance, or it's because of non-adherence, or anything else other than being in the clinical trial.
Dr. Susan Eshelman and others have been working on the resistance aspect of the antiretrovirals from our trials, and the issue of resistance is quite hard. I mean, every infant who receives zidovudine, probably by now they are resistant to nevirapine. So not zidovudine, nevirapine. The resistance is probably every infant is now resistant to nevirapine. Will this affect their chances for treatment? I think probably yes in the short term, but not in the long term. Regarding the mothers, there are other factors we do not understand very well. One thing about depending on one type of intervention, and that is antiretrovirals, is that first of all, antiretrovirals probably have nothing to do with infectious complications. It is not like the other interventions we did. So antiretrovirals will decrease transmission of HIV. That we know also from heterosexual studies. But the problem is that will they provide also the same benefits? You could say, well, you save the infant and then the rest is, they will survive. But there is more work to be done to tease out actually why some are transmitting and why some are not.
I saw a hand over here.
Yeah, I was wondering, you alluded to, kind of the huge ethical debate about what was appropriate control or standard of care. And I wonder, for your PROMISE trial and just for general clinical trials in Malawi or other similar places, has that debate gone away? Or, what's the status of that now? Because the Helsinki Declaration sort of supports the very stringent view.
Yeah, yes, and from time to time we run into some big debates, actually. I mean, be that the IRB here or the IRB in the country or within our own networks. But I think right now we know what the standard of care is. So there are clear or thresholds I mean, you have to provide this limit. So that part is now clear. At that time, this threshold, or what is the standard of care, was not clear when we were applying placebo, meaning not giving anything compared to the intervention you give. So that we were criticized because that was considered by some not ethical. However, the problem is, as you know very well, I mean, if you are not providing, or if you don't have an appropriate comparison, then to compare it with what? So that becomes historical data, other data. It becomes quite messy. So having said that, I think right now our challenge is more of the implementation aspects of you conduct a clinical trial, you have good results, then you leave it there. That is the challenge. So we are working through our networks. And I'm glad actually the funding agencies now, they are part of this process. In our earlier studies, if you are just wondering how did we survive for 20 years, we never shrunk. I mean, we were able to survive all these years. It is just competing, writing grants and things like this. But right now, the good thing is that be that NIH or other agencies are becoming more understanding of these challenges. So if you conduct a clinical trial and it is successful, then the burden is, in our case, it is the burden is on the investigator to try to find out what to do next, or what to do. Will you provide the treatment? Will you make it available? We are doing right now that part. I forget to say that everything I have said here is based on collaboration of so many people, from the sponsors to my colleagues, my colleague Newton Kumwenda, who is a faculty here, who is resident in Malawi, so he directs our work there. So it is a large collaborative effort between so many institutions. Right now, we have more than 230 people who are working with us, just to give you an idea how involving it becomes as you do these trials. But the burden is on us right now to provide the treatment if it is effective. And as I said, the sponsors and other people have become more understanding and accommodating, so they work with us to develop a plan whenever a clinical trial is effective. It is right now happening with a large trial. It is called 052. This is discordant couples. If you treat the index case, you can actually decrease transmission, 96% reduction. This was reported just 2 weeks ago. So we are one of the sites. Right now, we are trying to make antiretrovirals available for discordant couples. Probably I didn't answer your question straightforward, but...
Well, just to clarify, for the PROMISE trial, is the standard is the control group, the standard of care that would be similar to what a woman in the U.S. would receive?
It is, in the U.S., women do not breastfeed. So we have there is a big difference here. And PROMISE is basically to cover breastfeeding. So the PEPI Malawi, and there is another study called BAN, and another study called MABANA from Botswana. These three provide basically the standard of care for the PROMISE study. So it is an extended regimen.
One quick last question.
It's just a comment to this. Except perhaps in the HIV world, outside the HIV world, I think the new revision of the Helsinki Accords are basically ignored because they're so unrealistic and so fanciful that it makes no sense whatsoever. It would suggest that you could never do prevention trials for major maternal and child health outcomes, certainly, because the standard of care should be stuff that's completely undeliverable, right? So basically, the new Helsinki version is ignored.
Well, thank you very much. And if you have additional questions, maybe you have a few minutes to answer individually.
Okay.
All right.
Thank you.